obviously laryngeal hemiplegia is not fun, so we have to treat it surgically. So it's actually saying here, when horses are going at long distances and high speeds, you get reduction of the laryngeal aperture, so the opening, by 50%. And this increases the breathing 16-fold, so 16 times more. So obviously, if we don't get this sorted, it makes the horse's life a lot more difficult. And the procedures include a prosthetic laryngoplasty, so I imagine you remove parts of the larynx, a sacculectomy or ventriculectomy, ventriculocordectomy, reinnervation of the CAD muscle, so the cricoarytenoid one, and occasionally an arytenoidectomy. So if we do surgery at all, it's based on the idea of abnormal upper airway noise, so the whistling or roaring we mentioned, poor performance, or both. And the age and use of the horse also affects this, and the degree of the arytenoid cartilage collapse. So, sorry, it says there's a poor correlation between just using sound and the degree of airway obstruction. Like, the best way is obviously if you're diagnosing it with an endoscope. And also there's a risk of infection of bacteria coming from the lumen of the airway, so it's very hard to intubate horses. So this is a prosthetic laryngoplasty. So this shows the difference between before and after surgery. So this is known as what we call a tie-back technique. You place a prosthesis, usually a non-absorbable suture, between the cricoid and arytenoid cartilage. And basically the goal is of the laryngoplasty, you are meant to get some degree of permanent abduction of the affected arytenoid cartilage. So next it's the same thing. Okay, so this is how we do it. So it's performed in lateral recumbency, affected side up, and it can be done with a horse standing as well. So maybe this would usually be done in the field. You do an 8 to 10 centimeter incision on the affected side, and the incision will be about it says 8 to 10 here, but it says 10 to 12 here, so let's stick to this, 10 to 12 centimeters ventral and parallel to the linguofacial vein. So you can see it's parallel but ventral to that vein, linguofacial, and it's extending caudally, so towards the back, from a point 4 centimeters cranial to the ramus of the mandible, and they're sticking their fingers in there, or thumbs. So basically, when you go in there, you do a blunt and sharp dissection with Metzenbaum or Mayo scissors to separate the linguofacial vein from the lateral margin of the omohyoideus muscle. So I guess you cut the omohyoideus muscle along the length of the incision, and use before you stick your fingers in there, your index fingers, you cut use Metzenbaum or Mayo scissors to cut the omohyoid muscle along the linguofacial vein, and you use both index fingers into the incision to bluntly dissect through the loose fascia around the larynx. So that's how you access the larynx. You cut the omohyoideus by the linguofacial vein using Metzenbaum or Mayo scissors. Sorry for the repeat. Anyway, so we're going to get in there now. And what we're going to use retractors to be placed in the incision after you've done your blunt dissection with your finger, underneath the linguofacial vein and the sternomandibularis muscle, and retract them dorsally to expose the dorsolateral aspect of the larynx. The septum between the cricopharyngeus and the thyreopharyngeus muscle is split longitudinally with scissors to expose the shiny white muscular process of the arytenoid cartilage. So yeah, this is the muscle retracted. You incise the septum between the thyricopharyngeus and the cricopharyngeus. And that's it. And then you have the prosthetic laryngoplasty. Is it still the same? Oh, geez. Okay. So you have the muscular process of the arytenoid cartilage, which lies between the cranial parts of the, I'm trying to find the muscle. Okay, fine. Of the cricopharyngeus muscle and the dorsolateral caudal border of the cricoid cartilage to be exposed, and it's carefully dissected by the overlying fascia. So basically you cut the overlying fascia, sorry, I'm just trying to read this. To expose the cricoid cartilage, the dorsolateral caudal border. And then what you have here is There's a prosthetic suture, so you put your suture from the using braided polyester or nylon number 5 through the cricoid cartilage and through the muscular process. Okay. Oh, it also says here. Yeah, sorry, I thought this would be useful. It's not. Anyway, oh, there's more. Okay, so you basically use the suture and use the trailing ends of the prosthetic sutures underneath the cricopharyngeus muscle with a hemostat to just prevent bleeding, and the sutures are tied under tension. And the position of the prosthesis is to pull the muscular process caudo-medially, and a second suture can be placed laterally to the first laterally to the first one you did, but in a similar way. So yeah, try and pull the muscular process again caudo-medially with the trailing ends under the cricopharyngeus with the hemostats. And the degree of abduction can be observed in the operation with a video endoscope, and the abduction to achieve the maximal opening of the rheumatoglottitis cross-section is sufficient to allow, it should be 88% open to allow adequate airflow. So yeah, this is kind of what the process looks like. So you can see the trailing ends of the suture here going under the cricopharyngeus. And yeah, acts as a prosthesis. And yeah, we'll get back to the ventriculectomy.